Sveiki sugrįžę po pietų pertraukos, tikiuosi visi turėjo.
Welcome back after your lunch break, and I hope all of you have had the possibility to have some snacks and rest. And now we will go back to our conference, and I would like to give the floor to my colleague who is standing right beside me. She is the doctoral student Marcinkevičiūtė, a PhD student at the Suicide Research Center Department of Clinical Psychology, University of VILNIUS, and she will speak about the findings from the system evaluation study in regional areas with the highest suicide rates in Lithuania. The research was carried out last year, so probably you will feel to some extent the Hello, I am pleased to welcome you here at this conference. As Paulus has said, I am here to introduce to you the results of our research. The research deals with the efficiency of the support system, and I will step by step introduce to you what our findings are. These are our team members. You know some of them, Paulus and Saidas. They were speaking at this conference, and Dovilė, Jurgita, Austėja, Greta, Igne, they have contributed to this research. A little bit about the content of this research. A few words about how this research was born. 3 levels. It was carried out at several levels when analyzing the support at municipalities provided to suicidal individuals. First, it was the level of objective indicators, then the gatekeeper level, and mental health specialist level. And I will present to you the results and the recommendations. What is the context? Of course, you see the curve here, and this is the average of the Lithuanian average, which is several times higher than the European average, and it has been taking place since 2017. We see some slight reduction. It continued in the times of COVID, but we are not yet convinced, we are not yet sure why these indicators are decreasing, but they are still high. And we gave birth to this project after the national audit took place at the mental health system, revealing that there are many problems. So we decided to understand and discover why the problems were. We outlined 10 municipalities. Some of them are related, and this demonstrates the regionality aspects. They are at the outskirts of Lithuania, and the research took place in there. You may have seen this picture as another context, and it reflects what we tried to evaluate. The suicide prevention system provides support to risky people exposed to risk, and it demonstrates to what extent this help is accessible to people with various needs. And this picture demonstrates whether the support system corresponds to those needs. As I have mentioned, this research concentrated at 3 levels. These are 3 different levels, and briefly, the objective indicators level. Here we analyzed the data gathered at the health system, the Hygiene Institute, the National Patients Fund, and the compulsory health insurance, and we try to identify to what extent the services are accessible and how uh, the conditions, suicidal conditions are related to this level. Then we try to identify how ready the gatekeepers are to react to the situation. For instance, policemen, firemen, educational establishment employees, the municipal administration employees. We would like them to be able to notice suicidal risks and encourage and direct people to help institutions. Here we addressed 228 authorities in 10 municipalities, and we received approximately 140 research participants. They filled out long questionnaires, and we researched what their attitudes towards suicides are, to what extent it is likely that they will react, and to what extent they feel overburdened, what the welfare indicator is, and we wanted to learn about their opinion, how they view the health system. So a few findings from the data of this level. I will mention them later. And then we had yet another, a third level, that is the mental health specialists who directly provide help to people exposed to risk. Psychiatrists, psychologists, social workers, case managers, and even nurse. They participated in this research, and we interviewed as many as 30 such specialists. We wanted to find out about their experience when providing help to people exposed to risk, and how they view the system. And of course, we talk to them about help during COVID period, because our research coincided with the COVID, the pandemic period. I will mention that the project report is long, 200 pages long, so I will only review the most interesting data of the research, which seems to be worth discussing. I will immediately jump to results. And you see the first level, objective indicators, the data accumulated in the health system. You see an interesting graph, deaths by cause. This is the suicide curve. You see a small decline, and it is interesting to see the relationship with the registered deaths based on other causes. For instance, if we take this curve, we have unclarified death reasons, and it is increasing to compare it with the decline of the suicidal curve. Therefore, we may make a presumption that some of the suicides hide behind the reasons for these deaths. And in 2018, we even observed the symmetry. And these indicators exceed the recommended standard by 1.5 times. So the data confirms that certain suicidal indicators may hide behind certain other death reasons. Then we have the graph of lethal poisoning, and the indicators are 3.5 higher than the recommendations, and all people die by hanging a lot, and there's no indicator that suicide should be committed by self-poisoning. So this curve only confirms that death by poisoning, self-poisoning, may be hiding behind this curve, and the data maybe is not specific to its full extent. So our finding is that the specific data still remains an acute problem, and there are a few other arguments. For instance, uh, the incidents related to suicides are not registered in the health system. The conditions related to that are not registered, and um, there are registrations of conditions related to suicide one per one, but they should at least be by a dozen times higher per one suicide. So conditions are not registered. And there are also mental health indicators which probably are not registered either. I will move on to another graph. And here we can see the graph demonstrating meeting the context of people who died by suicide a year before their suicides. These are at the level of Lithuania, and then we have the different municipalities. We see that quite a number of those individuals 1 year before the suicide get to the health system, which means that they had contacts, and this was the resource was not used, because we see that the referrals to the mental health specialist are very few, and contacts with mental health specialists probably hide the meetings uh, with psychiatrists, and it shows that the referral to psychologists or continuous consultations are very few. So this is the resource not used to its full extent. And we have made the conclusion based on this data that the assistance provision system is not well developed, and we could train general practitioners and specialists and could ask them to observe the risk and direct to help, refer to help. And these are the contacts 1 month before suicide. And we see that in Adelina, 40% of people 1 month before the suicide addressed their GP or psychiatrist. In Kalvaria region, it amounts to 80%. So this area should also be developed. Now we will move to the gatekeeper level. And this graph is interesting in the fact that it reflects the likelihood that the specialists of various areas will react to suicidal risks and will refer the patient to the system. And we have now three specialists here, policemen, the elders of administrative units, and GPs. And we believe that they can help the individuals at suicidal risks. We have police officers whose indicators are very low, and it would be worthwhile and possible to include them in the health system. And if we want that, the indicators may be increased. They participate a lot in public life, and very often they go to the place of the incident if it is necessary. And now the elders actually do not have the necessary knowledge for that, and they are not confident that they can help people at the risk of suicide. These indicators are a resource which can actually be exploited. We have made a conclusion that a gatekeeper group is homogeneous, and they may respond to the various needs of the society. The next graph is the following. This will demonstrate, this will help you make an impression about the psychological health. We were asking whether those who provide the mental health are sufficient, and most of the gatekeepers believe that no, it's not sufficient. Moreover, others think that mental health is difficult to access. Bearing in mind that we expect from the gatekeepers that they will notice the risk and will direct to the health system, if they believe that this help is accessible with difficulty, they will probably there's a lesser likelihood that they will be able to refer the individuals. So this is another unused resource. Now, what are the mental health specialists who directly provide help? This is the quality level, and I would like to share a few quotations of the specialists. And the conclusions. One of the psychiatrists says it does not always happen that during your first hour you can find common points of departure with that individual and start talking to them. If there are loved ones around, then you ask them to look after that individual and we ask the individual to come to me in a day or two, and then we ask the loved ones to give some medication to those individuals at suicidal risks, to let them sleep better, and then during the second, the third visit, the individual opens up, and then you start speaking to the individual. And it is necessary to speak with the individual because when developing the assistance system, it is important that those individuals who provide support should have both knowledge and the skills to provide assistance, and there should be the assistance ensured so that the relationship is long-lasting, and it takes time to create such a relationship. What about the emotional context? We thought that the emotional context could be ensured, should be ensured, and these are the ways to ensure the ways to work with the suicidal individuals. For instance, the willingness to help and self-criticism, reflection on their own experiences. They feel shame and blame and fear and some stress and anxiety, and it is important that they define their role, and they feel sadness. So that only shows that the specialists work at under the conditions of increased risk, increased stress. One of the last findings is the following, the findings that I would like to share with you. Research participants were speaking about the state system and the algorithm in municipalities. That's a dream. And we should have a good network, and everybody should know who does what. And another psychologist says that this brings in some order, it protects the specialist. And based on that algorithm, we all try to work and provide help. And these quotations are quite numerous. What do they tell us? This is very interesting. We have a clear national strategy, which is like a backbone, a safe haven for them, and they want to have it as a resource. What are the recommendations based on the data that I have shown? Of course, it is necessary to increase the quality of data collection so that the situation is reflected better. And also, it is important that the assistance expansion, that the assistance is provided, and this assistance provision system is expanded. And of course, the support for each other is necessary. And this is the list of literature. This is the data related to COVID. And here you can find the report itself. Of course, it will be shared with you. Now, I would like to give the floor to my colleague who will speak about the research that she is conducting, and then she will invite you to participate at another research. I am Agnietė Čepulienė, and I also work at the Vilnius University Suicidology Center, and I'm a PhD student. At the moment, I'm looking for the participants for my research, which is related to the role of spirituality during bereavement after the spouses or partners suicide. And maybe if you found a participant, maybe that participant who has lost a spouse or partner due to suicide 1 to 5 years ago, could make an interview with us by video calls or live, and could tell about their spirituality or religious beliefs which are related during the bereavement process.
Na štai, dabar galime pereiti prie klausimų ir turime keletą.
Now we may ask questions.
Ar statistikoje atsispindi nusižudžiusių asmenų kontaktai su privačių įstaigų specialistais, psichiatrais?
Does the statistic reflect the contacts of those specialists who were contacted by those who committed suicide?
A very concrete question. What is BES? BES is a scale, a draft to evaluate if a specialist would react to the risk and would send a person to another specialist. How did you research the gatekeeper level? Yes, we used the same scale. In which region we have the greatest number of suicides and the deaths with certain causes, for certain causes. I don't remember exactly, and it's changing from one year to the other. It's not always in the same region that we have the highest numbers of suicidality. For example, in Pagėgiai we have a bit more than 2,000 inhabitants. So one suicide would amount to one suicide per 100,000 people. So in small municipalities, it's very important to see into to look into the details. Is the situation in Lithuania getting better or not, and how could we improve it? Yes, we do see that the situation about the data is improving. No country has the data in the perfect way because the suicide they get lost somewhere. Yes, for all of us, it's important to remind that it's important not to see only the data of the suicides. We have said that during the pandemics, the suicide rates have declined, but we should look not only into the suicide rates, but we should look into other causes of death. For example, if we have fewer suicides but more deaths that were unclear. So it's important to look into the data. To do this study is not only the police work to see if it was a murder or a suicide, but it's important to see to make a research and to see what is the cause of death, because in Lithuania we see that it's sometimes very difficult to determine if it was a suicide or if it was an accident. So we have been speaking about that with the Ministry of Health, and we will go on this topic because it is very important. May I add to it about the data? It's very important to speak also about the suicide states or suicide conditions. We have very few of them. I think that many people don't get help. They get lost somewhere and they don't get help. Okay, and the last question about the recommendations. Do you give recommendations about the psychological, psychotherapeutical help in these cases? It's about my personal recommendations? No, it's about the research. Do you give any recommendations in your research about the psychological help? No, we do not speak about one or two, but we should speak about the alliance, about building the relationship. So any method would work as long as it is a relationship creating method. Thank you, Migle, a lot about your research and your presentation. We will have a very, very short break, half a minute, and then we will go to the